Now let's go to Just Got to Do It by Dr. Mahesh. Dr. Mahesh is a consultant glaucoma surgeon at Ahilya Eye Hospital, Palakkad. And he did his UG and PG from JIPMER and fellowship from LV Prasad Eye Institute. And he has a lot of experience in MIGs. Over to you, Dr. Mahesh.
Thank you, Jonda, for the intro. Thank you, KSOS, for the opportunity. So, after discussing about intraoperative gonioscopy and all the trabecular cleavage procedures, which are limited to 120 degrees, I am here to talk about something which we can achieve almost 360 degrees trabecular cleavage. So, this is about gonioscopy assisted transluminal trabeculotomy or GATT. So I will be talking about what, when, how, and why. So the what of the GATT is about the introduction to the world of MIGS and about the GATT. And intraoperative gonioscopy, Dr. John has already spoken. The disadvantage of talking third is like, especially in MIGS, all the procedures to start, only the devices are different. The intraoperative steps, how to do gonioscopy, how to adjust microscope would have been already covered by the previous speakers. So, as John already showed, MIGS was described in 2012, almost 12 years back, and minimal trauma to the target tissue, faster operating time, modest efficacy, high safety profile, and rapid recovery. This is what we have at present with us, the whole of glaucoma surgery armamentarium. And on the left hand side, we have the MIGS, and I'll be talking mainly about the GATT procedure. So GATT was developed by Dr. Devinder Grover and his team at the Glaucoma Associates of Texas. It's a non-bleb forming MIGS procedure where the Schlemm's canal is de-roofed, and it's a conjunctiva sparing ab interno 360-degree trabeculotomy. It was started as a illuminated catheter-based trabeculotomy, and they do that still, and in resource-limited setting, and we can also do it based on 50 prolene suture. So both the speakers spoke about the microscope rotation. What I can add to it is this app, which is available on the App Store, and you have the equivalent apps in Android also, where you can place the when you measure the angle. So so it's always difficult to keep measuring it every time. So you measure the angle of 45 degrees, mark it, and then once you have marked it with a permanent marker, it's going to be there forever. And next time you don't have to, keep measuring it again and again. Since all the procedures are trabecular meshwork based, how to identify them? Obviously, by the grade of pigmentation. If you have a patient like pigment dispersion syndrome or a PXF glaucoma where the trab meshwork is heavily pigmented, you don't have much difficulty. Then you can do something called as a provocative gonioscopy and force the reflux of blood into the Schlemm's canal. And you can induce hypotony or a reverse Trendelenburg position. Dr. John mentioned about having the head above the heart so that you don't get much of blood while you're operating. But to visualize, we can give a reverse Trendelenburg position and keep the head below the heart level so that you induce some amount of reflex blood into the trab meshwork and into the Schlemm's canal and visualize the trab meshwork. And also, staining the trab meshwork with trypan blue also helps. Now, going into the when, how, and why of GATT, we have patient selection, pre-op evaluation, surgical procedure, and advantages of this procedure over the others is what we will be discussing. Patient selection, more or less, is the same what we have discussed. We should have a cooperative patient and patient who, since most of the procedure deals with tilting the head of the patient, you don't want to have a patient who has a cervical spine problem. The indications as such is mild to moderate glaucoma, but if you look at the innovators, Dr. Grover et al. And his studies, they do it in quite severe glaucoma also. And the amount of IOP reduction, what they claim is around almost 30 to 40%. But if you are going to begin your surgeries, you can better do it in primary and secondary open angle glaucoma. You can do it either standalone or with cataract extraction. Better to start with patients where controlled IOP on 2 medications. Preoperative gonioscopy is an absolute must in the office. And then practice few sessions of intra-op gonio in routine cataract cases. So here we have a routine cataract case at the end of it. You just have to put your gonio lens onto the cornea after putting the viscoelastic. Take a Sinskey hook, go visualize the, you can see that nice red blood in the Schlem's canal, which is the trap meshwork, and the, uh, so if you can see here, this is the trap meshwork behind which is the Schlem's canal. There's a roof, and then you have this scleral spur, then you have the ciliary body band or the root of iris. So you just need to go take your Sinskey hook and touch the Schlem's canal. And practice the motion, which we do it in either KDB or bang procedure or a tornado hook. So in combination with cataract extraction, we need to get a detailed consent. As we already discussed, the visual outcome will be a little bit delayed as against a cataract extraction alone. So you need to discuss this with the patient and have to get a detailed consent. Then discuss recovery delay and discuss the head positioning. When done standalone, pilocarpine drops 15 minutes prior to the surgery gives a nice constriction of the pupil and quite allows you to visualize the angle. Now, which to be done first? As Dr. Neetu said, like when she's doing toric or studies, say that you better do the procedure first and then do later. But when you are doing a MIGS in a normal case where you have glaucoma, if you feel that cataract is there and then the cataract is quite significant and that your cataract surgery might induce some amount of corneal edema, which might later hamper your visualization of the angle, better to do the procedure first. Do the rexis so that you don't, when you're intraoperatively, you don't touch the ALC and have problems with your rexis. So do the rexis, then fill the angle, fill the anterior chamber with viscoelastic, do the MIGS procedure, then finish up your cataract surgery. By doing this at the end of the cataract surgery, after IOL placement, you don't even have to wash the viscoelastic because that visco is anyways going to remain there for tamponade. So this is a study which said that there appears to be no significant angle visualization difference whether the surgeon chooses to complete the angle surgery before or after phacoemulsification. Therefore, the decision should rely on the surgeon preference. Intraoperatively, positioning as against the phaco, where the elbows are at sides, you are sitting straight and you are operating at a coaxial light. MIGS is arms straight, and you are doing a procedure where your one hand is extraocular and one hand is manipulating intraocularly, and there's a little bit of increased distance between where you are sitting and where you are going to be operating because of the microscope tilt. So this is the cluster of instruments that is currently being used when we do a trabeculectomy. And as against that, look at the amount of instruments that you need when you're going to do a GATT procedure. There is so much decluttering. All you need is 2.8 millimeter keratome to create the incision, and then you have the MVR blade, and then you have irrigation aspiration cannula, a direct gonio lens. This is what we have, the Grieshaber forceps, what they use for ILM peeling. You can have this. So this is what the forceps which we'll use to grasp the suture, Prolene suture intraocularly to pass the suture all along the trabecular meshwork. And then you have the 50 Prolene. So 50 Prolene, when it comes with the needle. And then as of now, we don't have the pre-tip made 50 Prolene available. So you just need to show it as close as possible to the cautery. This is a normal bipolar wet field cautery, and the tip of the suture will become bulbous like this. So you need to have something similar to this mushroom, which is a small mushroom. You don't need such a big mushroom which will bypass the size of the Schlem's canal. So I'll just show you once again. You don't even need to touch it. The only problem is most often, I think it's a universal problem, your cauteries don't work. And if you have a situation like where your cautery is not working, you can also have a flame in which you can heat up your either a iris reposter or a spatula and then show that heated spatula close to the suture. That will also make the tip bulbous. About the gonioscopy, few tips that I would tell is don't put the viscoelastic on the cornea. Put the viscoelastic on the lower surface of the lens so that you don't have viscoelastic spreading all over the cornea, because when you have created incision, suppose you have nicked some corneal blood vessel, that blood when mixes with that viscoelastic will hamper your view. So put viscoelastic sufficient amount on the back surface of your gonio lens and just use that. Depending upon the eye and depending upon your dexterity, you can rest your hand on the malar prominence or on the forehead. Then, when you are visualizing the angle with the gonio lens, don't use the gonio lens to look at the angle. Now you are visualizing that nasal angle. You want to go a little bit infronasal or supranasal. Don't use the gonio lens to tilt. Ask the patient to tilt, or you rotate your position, because by tilting the gonial lens on the cornea, you are going to put pressure, induce corneal folds, which is going to hamper the visualization. Then zoom into the desired area. So this is the intraop visualization of the nasal angle. A few tips about the wound construction: avoid the limbal vasculature. A 2.2 millimeter incision is sufficient. A temporal incision is what we do to access the nasal angle, because most of the collector channels are available in the infranasal quadrant. A tangential incision for the suture entry. I'll discuss about this in the surgical video. I already spoke about the advantage of intracameral pilocarpine. Then about the suture and forceps introduction into the AC. So we introduce the suture into the anterior chamber first. Then we introduce the Grishaber forceps into the anterior chamber. And then we put the lens. Because if you put the lens on top of the cornea and then start to introduce your suture or your forceps, because of refraction, there is a different in the level. What you see and what you are actually going to put, you might hit on the cornea, you might hit on the, if you're doing a standalone case, you might hit on the ALC and cause ALC trauma. If you see reflex heme, keep the eye firm by injecting viscoelastic. At the end of the surgery, half fill of the anterior chamber with ISCO or the air tamponade is what we desire. So here is a procedure. So you see the angulation of the MVR. This is what I told, tangential incision. By this tangential incision, so the surgery has been done. This is the clear corneal incision for the cataract surgery. Through this incision is what we are going to introduce our suture holding forceps, and this is the nasal angle. So by tangential entry like this, our suture will come and sit in this nasal angle. If you have the usual straight entry like what we do it in our cataract surgery or SICS, what happens is the suture comes in the center. Taking this suture from this center here to the nasal angle will create a kink in the suture, and that kink will not let you allow passing the suture smoothly. And there's a voiceover to this. Can you have the voice, please? You see how இதுல வருது. It's okay. So we have placed the suture inside. We are avoiding the limbal blood vessels. This was one of the very initial cases. So once you visualize the angle, you should be, the practice gonioscopy helps because you don't need to put pressure on the cornea to create these folds. When you have these folds, it's going to hamper your visualization. Then you take the MVR blade, go to the nasal angle, create a goniotomy. A successful goniotomy will have a little amount of reflex heme, and a nice white background. That's the, Schlem's canal. And then you have the suture. And we are holding the suture with the Grishaber forceps. We need to pass it along. And then once it's gone into the Schlem's canal, you just need to, thread it. It takes around 25 to 30 strokes of threading to get the suture all throughout. And every time you pass, there will be little bit amount of blood. Every time you see blood, please fill the anterior chamber with viscoelastic. And the first time you get that suture traveling 360 degree and coming back will be a wow moment when you will see the umbrella tip coming back. So it has gone and come back. And once it has come, you just hold it with the Grishaber forceps, the intra ocular part, and the outside one, you just hold it with the McPherson forceps, and then you rip. When you rip it apart, it just travels a complete 360 degree. So this is at the end of the surgery, this is a different case. What I want you to see is this quadrant. You saw the blanch. You saw this. See this blanch. See the blood vessels here. This is what Dr. Neetu had spoken about, the episcleral fluid wave. So when you tighten the anterior chamber, fill, you see this completely blanching. This is showing the patency of the collector channels. This is another case of silicone oil filled eye post VR surgery glaucoma patient with 4 medications. Patient was actually planned for a AGV. Intraoperative gonioscopy showed a open angle. Then we went ahead and did a 360-degree GATT procedure. At the end of the surgery, after 3 months, you can see the nice cleavage all around 360 degree, and the patient continues to be on only one medication now and well controlled IOP at the end of 3 years of follow-up. So post-operative follow-up, hyphema is expected. Like Dr. Neetu told, we need to fill the anterior chamber and fill the center so that the hyphema does not impair the blood visual acuity. What again we add on is we ask the patient to sleep with head end elevation so that the blood settles down. Initial post-op day IOP may be high. And depending on the severity of the glaucoma, it's the surgeon's choice, surgeon's call to continue the anti-glaucoma medications, step down one by one. At 1 week post-op, we change over to low-potent steroids or NSAIDs. Role of pilocarpine was, it's a debatable this thing. During the COVID, when there was no pilocarpine available, we still did procedures and we somehow managed the patients without pilocarpine. So at some point, if you feel that there is a small PAS, because you are creating raw surface, the iris tends to go towards the raw surface. If you feel that there is at some point a small PAS is developing, it's good to add pilocarpine. Advantages as against the other procedures, it achieves a 360-degree trabeculotomy. It's a cost-effective conjunctiva sparing. Mind you, all the procedures that we talk about is some time down the lane, you might need a trabeculectomy. You just want to postpone the time period, whether you give the patient a 2 years, 3 years, 5 years time for the trab to happen. That's all the idea of managing glaucoma itself. We keep on giving medication so that we don't want to do a trabeculectomy. Now we have SLT so that you postpone for 2 more years. Now you have MIGS, again another 2 to 3 years you postpone. It has a learning curve. It's steep, but it's short. Currently, MIGS, how much IOP decrease, how long, what's the cost, is it available to us? Yes. What we had a couple of years back and what we have today, we have a lot more options available. It's easy to learn. Finally, my take clinic message would be patient selection is the key. Intra-op gonioscopy plays a major role. About the procedure specific, tangential stab entry into the cornea to access the nasal angle. Avoid limbal blood vessels. In standalone cases, intracameral pilocarpine can constrict the pupil and help visualization. Achieving an adequate size of the mushroom tip of the suture. And finally, practice, practice, and practice. Thank you.
Thank you, Dr. Mahesh, for that